are you?
Good. How you doing?
Good. Thanks for joining. I was just saying that we are going to be talking about a number of different topics, but especially your course, Just Relax, Psychosocial Awareness and Trauma-Informed Care in Pelvic Medicine and Physical Therapy. So let's start. Tell us a little bit about you and how you got into this work. And
Okay, well, we've met definitely at conferences.
yes.
I'll tell you a little bit about my background. So I'm a couples therapist and an individual therapist and a certified sex therapist today. I mostly am treating patients is really what I do most of the time. But what got me into, I am doing a lot of work with trauma, as well as doing sex therapy and dealing with couples as well as individuals. But I think what got me into teaching about trauma-informed care, particularly for medical practitioners and specifically for physical therapists, is that I started my career in physical therapy. So I was a physical therapist for many, many years, and I was a pelvic floor physical therapist. And I specialized in pelvic health and sexual health, and also being from, I don't know if this has a lot to do with it, but being in a traditional community, many of the young women that would come to me with sexual pain disorders, with vaginismus, they would come for the standard physical therapy treatment with some amount of psychoeducation that pelvic floor physios provide. But the main work is working with getting to know your body and using vaginal trainers to learn to relax and kind of get your body used to intercourse. And at the time, I had very limited mental health training. But what I did notice, there were things that I noticed about some of the women that would come to see me. And also some of the things that women would say to me felt very disturbing to me. Things like, I really, really need for you to just fix me down there. Do whatever you need. It doesn't, it just needs to not hurt. Don't mind me. I just really need to have this fixed. It doesn't really matter. If I would bring up the idea of pleasure, this idea of pleasure was, not prioritized. I don't need to like it. I just need to do it. Not only did I feel like a great deal of anxiety, coming from my patients, I felt anxiety coming from the community, from the people that would refer, families, the great deal of pressure to consummate the marriage. These are women who were mostly having, trying to have sex from the wedding night on, many of whom didn't have any or very much prior sexual experience. So I was also noticing some amount of dissociation, and even though I wasn't trained at the time to recognize dissociative reactions, it was clear to me that some of the patients that I was working with weren't engaged with me, and I began to understand that these were trauma responses. It was easier to see the trauma responses when there were full out reactive kinds of responses, flashbacks, or a great deal of defensiveness and hyper reactivity. But it was harder to recognize when it was dissociative, when it was the freeze response. And that's one aspect of it. That's something that drew me into the idea of mental health. But another aspect was just simply being able to know how to say the right things, know how to respond to disclosures of abuse, know how to respond to other very intimate disclosures, know how to deal with the couples dynamics that these women would bring to me, particularly if they were based on fear. My husband's going to divorce me. I really have to. To some extent, I kind of felt like, wow, there are some women here that are even victims of domestic abuse, religious abuse, and I didn't really have the tools. And so that kind of propelled me to go further into mental health, but then also having the background in physical therapy, gave me kind of the ability to speak the language of physios. I was actually teaching this before I became a sex therapist. I was already starting to teach trauma-informed care to fellow physios I had also developed a protocol, a mindfulness-based protocol, and I also published about the mindfulness-based protocol for the use of dilators with vaginismus. And so that's kind of how it just got me forward into working in this field.
So I think there's two things that really kind of stuck out to me in what you said. And the first is, it sounded like a lot of your clients or patients were, so distanced from the thought that this could feel good and be pleasurable, and more focused on partners, and wanting to
partner's pleasure,
right, for that. And the second is just the, how important it is for sexual health professionals to have some knowledge of the mental health component that can play a role in so many of these physical, presenting issues, specifically when it comes to trauma and the reactions like dissociation and, pain. So if you could talk a little bit more expand on like why sexual health professionals need to really be both trauma informed and understanding of these mental health issues.
Okay, so there's a couple of reasons. First of all, the way that patients show up for sexual medical care, or even sex therapy, which is provided by mental health professionals, but many of whom have a very behavioral approach. So knowing two things. Knowing, first of all, how to interact with patients who have symptoms of trauma, who display symptoms of trauma in the clinic, because often sex therapy interventions can be likely to be triggering. So for example, if somebody comes in and they have, desire disorder or arousal disorder, or one of these pathologizing kind of names that they come in with, something's wrong with my wife, she's not enjoying. And, a very well-meaning sex therapist is giving her guided masturbation. Okay, well, if she's a trauma survivor, if she's a sex abuse survivor, this type of overstimulation may actually be very, very triggering, and she may very much avoid that because the wiring of direct stimulation may be very tied in with feelings of guilt and shame. So it's really very important to, even if you're not a specialist in treating trauma, knowing and understanding what are the outcomes for women and men who have experienced trauma, and knowing also how trauma affects sexuality and sexual function, and also knowing how non-sexual trauma can affect sexuality and sexual functioning, not just in terms of intimacy, because I think most mental health professionals know that PTSD or anywhere on the spectrum of trauma, even if it's not sexually based, often results in emotional dysregulation and other sorts of features which are not particularly relational. So we all know that intimacy can be disrupted by trauma, but people are less aware of how actual sexual function can be disrupted by trauma. The nervous system really needs, in order to completely relax during sex, in order to really enjoy sex, your body really needs to be able to have the experience of safety. The body keeps the score, and the body very much holds tension. And this idea that people who have survived trauma, they haven't survived trauma by letting go of their bodies. They've survived trauma through hypervigilance, through being really aware of their environments. So the idea of telling them to just relax, just let go, that could be taking away their adaptive mechanisms and create a lot more defensiveness, because they need to be able to have that hypervigilance. So really kind of understanding the neurophysiology, understanding the cognitive ideas around sex. I'm an object, sex is something that I have to do because somebody else wants it. Really understanding how patients with trauma, whether it's sexual trauma or any kind of trauma, how they might show up, and how your relationship as a practitioner is important and maybe something that you're not used to. So if you are a therapist, you will know that if a traumatized patient is having trouble connecting to you, doesn't trust you, doesn't show up for appointments, you'll know. You'll know why. You'll understand that people who have a history of trauma, have certain, have difficulties with connection, difficulty trusting connection, whether it's sexual trauma or narcissistic abuse or any sort of. But a physical therapist, a nurse, an occupational therapist, a doctor, anybody who's very well-meaning in the medical profession, they may not necessarily understand why their patients are acting that way, and they might attribute it to, non-compliance.
Yep.
And they also may not recognize freeze responses, and they might attribute that to, consent. They might consider it consent when in fact the patient is really unable to say, please don't do that. I don't want you to do that. I don't want you to examine me, or I don't want you to insert anything in me.
That's okay. But what stands out too is just the amount of damage that can be done, and the re-traumatization and the harm that can be done. It's not just like you should be to be even a better professional, right? You should be trauma informed to be a better professional. You should have some background, but you can do such damage if you're not.
Right.
Merely your responses.
Right.
Yeah.
And I do want to emphasize that compassionate and empathic, and do pick up on these. I mean, when I teach physios, I often feel like, wow, I'm teaching you things that you kind of instinctively already know. But that not all, I think that there is something gained to really, I think everybody really wants to learn, how do I take universal precautions to avoid, because I am sure that I've done that without meaning to, without intending to, but I'm sure that, I have made things worse for people by not necessarily knowing or understanding how important it is to really make sure that they know what consent means, to recognize when they're disassociated, to not collude with this idea that, they have to, they should. And, sex therapy, physical therapy is often a very progressively based intervention. Sensate focus 1, then sensate focus 2, then sensate focus 3, dilator 3, dilator 4, dilator 5. And, the medical professionals do have a tendency to want to push patients ahead. It's normal. But in this field, especially when there's trauma, we have to be exquisitely careful in really making sure that our patients are present, engaged, consenting, wanting, able to say if they don't want, able to make boundaries. And we constantly need to check in with them if what we're doing is okay for them. And, also changing it, if there's a contract to do something, that contract can be changed at any time. So it's a lot of communication, but even moderating the communication, like, am I talking to you too much? Do you want me to stop talking so much? I mean, it's really a lot of questions like, well, how is this for you? Because they weren't asked that. They weren't asked that when they were abused. They weren't asked that when they were told, this is what you do. When you get married, this is how you do it. And they weren't told about consent, maybe they were told about pleasure and they're just kind of waiting for that to happen, but they really weren't given a language for negotiating consent.
Yeah, and so you mentioned some of the ways that trauma can affect both sex therapy and physical therapy interventions. Any others you want to sort of add to that?
Well, I think that, anybody who's involved in the sexual health, or really anybody in mental health, needs to be, well, if we kind of break it down, if we go to anybody in mental health, you're talking about ultrasound technicians, you're talking about nurse practitioners, you're talking about anybody who's dealing with the body. And when I talk to physios, I talk to them also physical therapists who are not pelvic floor therapists, anybody who's going to touch a patient, do something with, I don't know how it is in different states and different countries, but very often you go for medical treatment and, just things are done to you. You're being asked, can I do this? Can I do that? Is it okay if, or, even language, the language is so important, rather than say, okay, this is what I'm going to do, but rather say, okay, what I'd like to do is that okay for you? Using this language of, is it okay? And you can say no.
Yeah.
And that's so new to so many people.
Well, even from the very beginning, right? With most doctors, where you're actually getting examined, it's, get undressed, put on this gown, and then someone leaves the room, right?
Sure.
Listen, I'm someone who's like, okay, I'll just start undressing when someone's there, right? But there's a lot of people that you need to give them, the ability to not do even that. Like, ask them if they're comfortable undressing, ask them what they're comfortable with if they're not. Obviously there's certain exams you can't do if you're dressed, but nowadays medical professionals are just always in such a rush that you don't give somebody the opportunity to be able to feel comfortable. And you know what happens? People avoid going to seek medical services, as a result.
Right. Yeah, you can't blame them, because if they're on some instinctual level understanding that they're going to be triggered or they're going to be re-traumatized, they're not gonna go. And even the idea of asking about abuse, asking about trauma. Many professionals really have not been taught how to do that in a sensitive way. And, and even the question of, is it going to be appropriate to do that? And what are you going to do if they say yes, when you have exactly 7 minutes with each person? And maybe sometimes some sort of disconnect with the provider is appropriate. There are people who will say, don't get into it. Don't get into their history. Don't get into, just maintain this kind of disassociated disconnect, because it might actually, the patient might be very much prepared to go through it that way. And forcing a connection, forcing an engagement could backfire as well. So that kind of nuanced ability to ask and know and be sensitive to what the patient wants, that's really important. It's really about connection. It's really about treating the person as a person and not an object, because they've been objectified. If they've been traumatized, most likely they've been objectified, depending on the kind of trauma. And again, even non-sexual trauma, certainly any kind of developmental trauma, so CPTSD, is going to have very similar effects on the hypervigilance, on the need to defend and protect. But again, like anybody who's been through something that has rewired their nervous system in that way, we do need to understand both how it will affect the intervention, but also how it generally affects sex and sexuality.
Yeah, such good points. Thank you so much. Can you talk a little bit about the class so that people know what to expect if they take the Just Relax Psychosocial Awareness and Trauma Informed Care?
Right. Yeah. So we put together with the Modern Sex Therapy Institute a 5 academic hour course that is geared towards mostly therapists, physical therapists, or sexual medicine specialists who are RNDs. But I have a feeling that all kinds of therapists, counselors, can really benefit from the course. What we kind of talk about is, what is trauma? What is PTSD? What are the, you know, what are the psychological factors in treating patients with trauma, with trauma histories, when you are not a psychologist, when you are not treating them from a mental health perspective. So how to recognize when to refer. Not everybody will already be seeing somebody. You know, like somebody may, very often, a woman goes to her doctor and she can't have sex, or sex is painful. The doctor sends her to physio without necessarily sending her to a mental health professional, which can make sense because, you know, to the doctor, the symptoms are she just needs to learn to relax her pelvic floor muscles. But there may be obviously a great deal of anxiety and protectiveness and a background of trauma. So knowing how to recognize that in the clinic and knowing how to refer and to refer sensitively. Participants in the course will learn how to identify and respond to trauma responses. So whether they're dissociative responses or whether they're very high arousal type of flashbacks or very high arousal responses, they'll learn how to ground. They'll learn how to bring people back. They'll learn how to recognize their own discomfort, because it can be really uncomfortable if your patient is dissociated and you can't get them back. It can make the practitioner feel very anxious. So, you know, learning about the mindfulness protocol, if you're a physio and you're working with patients with dilators and you want to help with addressing their aversion, addressing their fear, the mindfulness-based protocol is a very gentle, non-coercive, engaged way to work with your patients. So it's a 5-hour module. I think we have there's a lot of psychoeducation. There's a lot of behavioral techniques, not just for sexual pain disorders, but also for arousal and orgasm, understanding that for many patients with sexual trauma, arousal itself can trigger trauma responses. The arousal itself is wired in. And to understand that for many patients, you know, like there are cultural backgrounds to their trauma. Okay, if you're a young man and you grew up in a culture where it is forbidden to masturbate, and there are religions where it's forbidden to masturbate, and so you masturbate, every time you masturbate, you're going to feel a great deal of conflict, shame. So that, you know, so even when you get married and it's already sanctioned, you're allowed to, because you have a wife and it's normalized at that point, the very experience of feeling aroused may trigger this trauma, which is really like almost like moral injury for some of these men, because they battled so hard in their single years to not do it.
Yes.
So really understanding the cultural elements, it's a biopsychosocial, and the social aspect also in terms of seeing sex as an obligation, feel, and I think that this cuts across cultures. Yeah, you know, I think that even in modern Western cultures, women still continue to hold on to this belief that if I got him started, I got to finish. You know, like I can't. I have to finish what I started, and it's not okay to stop in the middle, even if it's painful for me, or even if I don't want to continue, or even, you know. So I think that being able to really be very psychoeducational about the importance of bodily autonomy, having, you know, it's your body, because again, the sequela of sex abuse is you lose your autonomy over your body. So it's your body, and you have agency. It is up to you to decide. And for many, many people, for many women, that's such a breath of fresh air, because they weren't taught that way, unfortunately. They weren't, I mean, they were sometimes even taught, you know, look, this is what you have to do. And that can be a type of trauma. People often ask when they see a woman, let's say after 6 months or a year, and she's got real traumatic responses, they'll say, okay, well, it sounds like you must have been abused or you must have had trauma in your past. And what they don't necessarily recognize is that the trauma is not from the past. The trauma is happening now.
Right.
And not because her partner is intentionally abusing her. It's happening because he himself doesn't know that this isn't okay. He himself wasn't educated about consent. And so I'll see couples after several months, sometimes even years, where this kind of dance of, we have to have sex has been going on. And, obviously the amygdala is highly wired to avoid even giving a hug or speaking in any kind of intimate way, because if I do that, then this will happen, and then we'll have to have sex, and kind of breaking that pattern, redoing it, creating safety. Creating safety is important in the couple. Creating safety is important in the clinic. This idea of creating safety in order to even be able to calm the nervous system.
Yeah, so important. I hope people will check out the course. It's on modernsextherapyinstitutes.com website. You can either search pelvic health or you can search Talli, because we're here with Talli Rosenbaum. And this has been incredible. I know we've been getting some appreciative and great remarks and comments. So thank you all for listening. Talli, thank you for being here for the fantastic
Thanks for
course.
hosting.
And
thank you.
We'll see you soon.
Okay.